and Oral Pathology at College of Physicians and Surgeons of Pakistan, University of Health Sciences Lahore, Punjab University, Gandhara University, IFMS Islamabad, University of Bolan, ISRA University, and University of Lahore. He is Fellow Regent, International College of Dentistry, Region 24, Afghanistan and Pakistan, and remained Chief Editor, International College of Dentists from Section 15. He has been elected as President, Central Council, Pakistan Society of Oral and Maxillofacial Pathology, President, Pakistan Dental Association Chakwal, and Pakistan Medical Association Chakwal. In addition, he is also a fellow of Pakistan Association of Oral and Maxillofacial Surgery and Pakistan Society of Oral and Maxillofacial Pathology. He is a regular presenter in many international conferences with special reference to International College of Dentistry as invited speaker. He has more than 100 original publications of his research work on oral wound healing by laser, ankylosis of TMJ, dry socket and its etiology, oral radiology, oral surgical procedures like multiple grafts, implantology, periapical procedures, and oral facial disease management, especially in trigeminuroglia. He has won the Best Teacher Award of the Year thrice. Now he is serving as a Dean Principal HBS Dental College, Islamabad. Now I will introduce about the online course of TMJ. Association of International Dentistry, pioneering online courses in collaboration with International College of Dentistry, Region 24, has started a series on temporomandibular joint with worthy speaker, Dr. Mahmood Malik. Up till now, Association of International Dentistry has conducted 3 sessions of temporomandibular joint. First session was on anatomy of TMJ, in which basic structure, articulating surface, ligaments and movements, along with nerve and vascular supply. And second session was on disease of TMJ, in which we discuss about clinical correlationship, causes and symptoms. And third was on diagnosis of temporomandibular problems, in which ways to observe and examine the cause of pain. Now, get ready for the final session of last season of temporomandibular joint series, in which we will discuss management of temporomandibular diseases, which can either be surgical or medically treated. Now, I will discuss about how to get certificate. Certificate that is internationally accepted will be provided to those who secure 70% above in the quiz, but only for the one who is registered. Attending the lecture is mandatory, otherwise certificate will not be provided. If you have missed any portion, you can watch it from YouTube and then attempt the quiz and get your certificate. If you an AID Executive Ambassador, you will be able to attempt quiz also from past session, get their certificate as well. Now I would invite Dr. Mahmood Malik to please start the final session of management of temporomandibular diseases.
Thank you. Thank you. It's a very long and too much added. I'm thankful to you, lady, that you have given a last section of my introduction. The thing is that this temporomandibular joint actually is a big, what you say, a series which has been covered by the Association of International Dentistry and as well as in collaboration with the International College of Dentists. We have covered many things. You have described everything. And now we are going to start our, what you say, last session. And that will be with reference to the management. It is very pleasing to be standing beside this great mountain of K2, and it is like very pleasing as well that when you see this mountain without clouds, in whole the year, K2 is covered by the clouds, and very rarely uh, near the glacier, that glacier is called as a Godwin-Austen Glacier. This Godwin-Austen Glacier actually is the glacier which starts right from the bottom of the K2, and it's a run approximately 5-6 miles till the Godwin-Austen ends, and from there the small channels of the water, it starts like that. You can view the mountain from Concordia. It is quite away from the K2, and Concordia gives a very pleasing image of the K2. But to reach to the base camp and reach to the what you say Godwin-Austen, it is usually used to take 2 to 3 days. Then you reach to Godwin-Austen, and this is a very lovely place. Although there are so many lucky people who has climbed up to this great mountain, and while you are standing beside these great things, you always feel pleasure. Ladies and gentlemen, while we are talking of the temporomandibular joint management, we have covered in the last session patient education and home care instruction, and that has a very good impact. I've received so many your messages and emails, and I have replied to that. There are certain questions that we want to get this backup or a recording. So, ladies and gentlemen, this recording is there on the International Association and Dentistry site. You can have the YouTube and you can check this all previous lectures. We have 3 episodes of sessions which we have converted into seasons, and every season has 3 sessions, and every session has 2 or 3 lectures. So today was the 4th session, and this is the last what you say lecture and last part of this whole great ocean of temporomandibular joint seminars. Last time we have discussed the physiotherapy and to some extent the exercises. Today we are going to give you a very important lesson with reference to intraoral appliances therapy. These are also called as occlusal splints. Prosthodontists, maxillofacial surgeons, general practitioners, and especially I will say the final year student must have the concept of this intraoral appliances therapy, because they have to give this intraoral appliances therapy to their patients. Now, while we are talking of the occlusal splints, that means that we are going to place the acrylic made any plate in the occlusal plane, either in the upper jaw either in the lower jaw, and our motive is that we create a distance between the joint and the temple area. The bone is temporal bone where the glenoid fossa is, and the condyle is in the mandibular bone. In between them is the disc. Now we have the multiple problems with reference to diseases, and we have discussed these problems in detail. They are muscular nature, they are related to psychological problems, they are related to your functional problem, and directly they are related to temporomandibular joint disc rearrangement. So whatever the intraoral occlusal splint we are going to give, we have all these three tasks in our mind that we are going to correct with these difficulties. Now, what is the purpose of giving the occlusal splint therapy? That is, number one, stabilize or improve the function of temporomandibular joint. And I have written giants because on the bilateral we have to cover the disease. We have to cover the disease if it is more on right side or it is more on left side. On the both side, we have to think that which splint therapy will be accurate to cover this discrepancy. Number two, our motive is to improve the function of the masticatory muscle and reduce the abnormal muscle activity. The splint should be constructed or fabricated in such a way that that particular patient, whether he has occlusal problem, whether he has muscular problem, whether he has any discal problem, must be compensated by the improvement of function of the masticatory muscles. And the last is that we have to protect the teeth from a traumatic or adverse traumatic loading. That is, traumatic bite, pencil bite, nail bite, thumb bite. If the splint is there and if anything is there, we are going to control that traumatic bite as well. Now, this is the goal which we want to achieve by our occlusal splints. Now, coming to occlusal splint therapy, it should be non-invasive, because if it is invasive, then what the benefits you are going to get? The invasiveness should be understood, that it should non-invasive to teeth where it is being inserted. It is non-invasive to the cheek. It is non-invasive to the palate. It is non-invasive to the tongue, as well as it should be non-invasive to the gingiva as well. So its construction, it should be very micro. Construction should be not vague. When you are constructing occlusal splint, its polishing, its roughness should be very nicely monitored. All the edges should be monitored. There should not be sharp or cut wide or anything which is pinching to cheek, palate, or opposing toe. So these are the things that the first monitoring is, that you take the appliances in your hand and you will check that this appliance is non-invasive or non-irritating. Next is the reversible. Reversible is that biomechanical method of managing pain and dysfunction of the TMJ and its associated musculature should be managed. And when it is managed, it should be in such a way that management should be a equilibrium. When with the passage of time you are going to omit this splint, this therapy or this standard of management should remain with the patient without occlusal splint. So that should be your target, that when I will remove the splint, its construction and its behavior and its myofunctional, what you say, therapy should be in such an oriented way that when I omit this therapy, our target should not be hurt. So this is the occlusal splint therapy. Before getting the occlusal splint therapy, these things should be in your mind. Now, the best thing is, what I prefer is you take the impression by the previously people used to favor it by silicon and very accurate formation. But what my experience is that whenever you take the silicone impression or the soft putty impression, what we get that we have the many undercuts, and these undercuts used to hinder the insertion of the splint, and you have to cut many ways, or either you have to trim the model to reduce these undercuts. This is very important. While when you take the impression with alginate, and that we are saying that when alginate is when you remove the alginate, automatically due to the path of removal, these maximum undercuts, they are being managed. So we prefer that for the occlusal splint, the better thing is that you take the alginate impression. As compared to that, you are going to take the silicon or very sophisticated impression. After taking the impression, you make the model and let the model to have with not with the soft plaster, always with the hard plaster, and then you are going to prepare the occlusal splint. Now, what the occlusal splint we are generally making, that is permissive one, and second is directive. These two are very simple to understand. If you see the permissive, we see the lower occlusal level is not being interdigitated. It is a smooth and plain. It is a very small dip, say it is 0.5 mm. That is, we used to create here that it should rest in the occlusal slot, not more than that. It is just to facilitate the occlusal splint to reside on the what you say, on the opposing toe. Otherwise, it is basically attached to the upper one, and just it is giving you the interdigitation of the. While in the directive one, we give the interdigitation both in upper and lower, and this interdigitation do not allow the movement of upper and lower jaw while then splint is positioned within the oral cavity. In this condition, the interdigitation in upper and lower is so firm that if you want to move the jaw, you cannot move it easily. And this is what we say, it is the directive one. And this is what you see, a permissive one. according to the requirement of the splint, you are going to give the directive one or you are going to give the permissive one. Directive one is very promising in the later stages, because in the initial stages sometimes it is very difficult for the patient to retain its position, and a patient feel very uncomfortable. But the permissive one in the initial stages is good, and patient generally used to tolerate it. And as the time passes, you convert your splint to the directive one and you stabilize the thing in later on. This is how you go forward. Next is that these are the types of splint which we used to give to our patient. One is called as the anterior biplane. Second is called as the posterior biplane. Third is called the full coverage maxillary. And fourth is called as the full coverage mandibular. Now, these are the four types of the splint we used to prefer. But when we construct or fabricate anterior biplane or posterior biplane, generally we used to give the retention in upper jaw. While in mandibular or maxillary, it is our own choice that we want to give maxillary or first we want to give mandibular. According to the case we will discuss later on, that we decide the full mandibular or full maxillary. Now we have to give anterior biplane or posterior biplane. Ladies and gentlemen, these are the basic bite plates which we have to consider in our practice. Now, these occlusal splint or occlusal have the 5 categories which we have there. One is the joint stabilizing splint, anterior repositioning splint, anterior bite plate, posterior bite plate, and lastly is the soft resilient splint. So don't worry, it is very easy to understand and it is very easy to get a concept or education of the appliances which you are going to use. The first we take is the joint stabilization splint. The joint stabilization splint is very important, and generally we consider joint splint as the initial therapy, and this initial therapy is very what you say important to be understood. The joint stabilizing splint have these possible effects. Number one, it decreases the loading on temporomandibular joint. Number two, it reduces the muscle hyperactivity. Number three, it distributes the forces created during bruxism. And very important is the repositioning of the mandibular condyle. The condyle has forgotten its positions. Now, decrease the loading on temporomandibular joint is that it has just fabricated joint stabilizing splint. You must understand that it do not give load to upper or lower jaw. It just give an impression. You take upper jaw impression and you fabricate the splint, say 1 mm to 2 mm is the least one, 3 mm is the maximum one. You just take this occlusal. 2 mm is very comfortable for the patient, and 3 mm is maximum you can have. If you are going to exaggerate this thickness, the patient will be not comfortable. The disc, when you place the splint, it give a distance from the temporal glenoid fossa to the joint. It gives relaxation. It comes down. Now what happens? There is relaxation of all the things. What are those things which get relaxed by giving this splint? Number one, the space is in lower joint space. There is relaxation. The disc is now free. Disc is now free. The freedom of the disc results into relaxation of the posterior ligament as well as the anterior ligament and the lateral pterygoid muscle. These three things get relaxed when the joints come down. When the joint can come down. Now, this is the position of the condyle, and all the ligaments posteriorly, bilateral ligament, anteriorly, the lateral pterygoid muscle, superiorly, the disc, and inferiorly, the lower joint space, these are relaxed. When this is the position in the condyle loading is gone. And this is the decrease in loading on temporomandibular joint by this giving the stabilizing splint. Second is the muscular activity. The hyperactivity is by without check. You see, when you have no splint in your mouth, your muscles are moving right, left, up and down, and you are clenching in all the way. So when you give a splint to the oral cavity, the muscular activity is by checked by that digitation, which very small digitation which you have given in the splint, the lower jaw is being obstructed or being checked. So what happened? That you want to have the bruxism, you cannot do it because there is a check of the splint grooves, and these grooves do not allow the hyperactivity of the muscle to grind itself with the opposing tooth. So that is the reduction in the muscular activity. Third is it distributes the forces created during bruxism. You see, the plate of the stabilizing splint is one unit, and it is attached to all the teeth. So when there is no splint and teeth bite with each other in this pattern, so there is individual grinding. There is individual grinding. But when you place a splint in between this, see, this is the splint. You place the splint. Now when you grind is like this way, upper and lower, like this. Now you are grinding on the splint. So what happens? That splint is taking the forces, and these forces all are being distributed throughout the arch. So distribution of the forces results into less bruxism, secondly less grinding effect on the tooth, and the vertical length of the teeth will not suffer. So this is another important thing, that when you give the bruxism, what you say, a stabilizing splint, in bruxism there is distribution of forces. The last thing is repositioning of the mandibular condyle. This is very wonderful phenomenon. Nature is a very good guideline to our body. We have to just give the body just a sport. Other guideline is a natural phenomena which God Almighty gives to us. Now, what guideline we are giving? The guideline is occlusal plane. We have given the occlusal plane and we have stabilized the occlusal plane, upper and lower occlusal plane by a splint. So what happens that when the tooth is guided in the occlusal plane, it is not going to distort, it is not going to distort the sorry ladies and gentlemen for a while. So repositioning of the mandible is being done by the guideline of the interdigitation by the occlusal plate. That occlusal plate will guide the upper and lower teeth to be in a very occlusal level in the centric position. That is excellent. Now, tooth is on the center occlusion. What will happen to the condyle? Condyle will go into a centric relation and centric position, and it will stay at its maximum natural level. So during this position, what will happen? The ligament will start repairing. The last portion of the disc will start repairing. The lateral pterygoid muscle will leave its spasm and get relaxed and try to be as natural as it was before the spasm. So by giving the splint, what we have achieved decrease in the loading of the joint. We have reduced the muscular hyperactivity. We have distributed the forces of the bruxism, and lastly, we have facilitated the mandibular canine in actual natural position. So, ladies and gentlemen, this was our task which we are going to get. Now, the joint stabilization splint, what area is used to cover? All the teeth as well as the area without teeth, if these areas are opposed by the teeth in the opposite arch to achieve the optimum stability. You see, these are the areas where the tooth was removed. And we have the posterior, this small tooth is there. We are going to give a splint in such a way that this, you see, very small interdigitation, and this area is being interdigitated by these cusp of the opposite teeth. So the mandible will get stability. So we have to achieve the maximum stability so that it should not dislodge and it remain maximum in the joint stabilization. Now occlusal adjustment is very important. It is very important to recheck the occlusion at the follow-up, since the occlusal relationship may change. As the consequence of jaw muscle relaxation, the forcing the mandible in more backward position. This is very important to understand. Very, very important to understand. You see, all the muscle of mastication, they are attached to the ramus. Coronoid process, condylar process, medial side of the ramus, outer side of the ramus. These all muscles, they have the maximum pull superior and posterior, while very less is the anterior and downward. Downward is hardly by the principal muscle of mastication. It is by maximum by the accessory muscle of mastication. So very slightly you can say that the medial pterygoid anterior head slightly give a downward pull. Otherwise, it is also not at all. So downward pull is not there, or it is by the accessory muscle. The upward pull and the backward pull right started from the temporalis, lateral pterygoid, medial pterygoid, masseter. It is mainly upward, backward, or right left. So when you give a relaxation, so what happens? The relaxation favors all those forces which are maximum in power, and those forces are all the forces backward. So what happens? That during the muscle relaxation, the jaw used to move back, and due to this backward movement, what happens? The condyle move more backward. And we don't want that it should go more backward, because if it is going more backward, it is stressing the bilaminar zone more. It is going to give the pressure on the posterior aspect more, which we have studied in the etiology and which we have studied during diseases. So secondly, the posterior compartment has the more muscular supply. The posterior compartment of the joint has more neural supply and vascular supply as well. So when you place the mandibular splint in the posterior level, what will happen? That the compression in the posterior side will increase, and that the target will, ladies and gentlemen, we want to achieve will not be achieved. So it is better that the condyle should be relaxed. Either it is slightly apart or it is slightly anterior. We don't want it should go back or compress. We want it should be relaxed or slightly anteriorly positioned, where we have the fossa, where we have the maximum disorientation, where maximum gliding and relaxation is there. So for that purpose, next time when the patient comes, because you have given a very slight interdigitation and the patient is biting posterior. So for that purpose, what will you do? That you take the bite and you bite. If it is posterior bite, you will going to have the check that muscle relaxation should not change the occlusal relationship, and it should be in a very accurate position of the occlusal bite. And that is what we are going to check the next time. Now that is the way that you ask the patient like this.
And we're using 20 micron articulating paper. Could you stick that up for me?
You see, by taking this, you get the high spots high spots, and there are multi. If you get maximum high spots, that is promising one. If you get two or three four, more than four high spots, that is a challenging one. You have to release these four spots. If any high spot give the clearance in the center, that is very bad. That means it's too high. So you have to go for that clearance in the occlusal splint. This I just give you the repetition that you can check it.
Open. Open. And we're using 20 micron articulating paper, which stick to the form.
And you will remove, and now you see it was very high spot here, 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 here. So that is how to check the occlusal advancement and how to check the high spot.
And we're using 20 micron articulating paper, which stick to the form.
So now the use of stabilizing splint. Primarily it is at night, because at night use is promising in the initial stages. Patient is psychologically depressed, and especially the young ladies. If you give the occlusal splint, you ask the patient in initial stages, we are whole the day, just give the splint at night, patient will be relaxed. Relaxation due to muscular spasm, relaxation due to joint relaxation, relaxation due to a reduction in the hyperactivity. Patient will automatically will favor more comfort as compared to pain. At that stage, when you will see that patient is saying, oh, doc, I am wearing at night and I am very comfortable. Then at that time, what you say that you are going to have the use in full time. Now there is very important thing to understand: the static pain and dynamic pain. Static pain is always muscular involvement, while the joint pain is the reciprocal click without reduction. These are things which we have studied in our diseases and in our etiology. You well know that. Now, in that case, if you feel that it is not involving and it is involving only in the muscular level, that is the best thing to start with the night. While the joint is there and the joint click is there, reciprocal click is there, medial shift is there, or what you say that without reduction is there. So at that time, you have to give the full-time use. Initially at night, and then you start the patient going for the full-time use of this, what you say, supplement. In acute cases, especially patient with the severe pain, with the severe trismus, with more hot points of the muscles, different spine, more neck rigidity, more spasm. Patient don't allow to let you touch your angle of the jaw. In these conditions, if you feel that the patient is in real agony, then it is better that you ask the patient to wear the splint throughout the day. And as you get the relaxation with the passage of time, you are going to reduce the time. How to reduce the time? First, you ask the patient when wear whole the night and wear in the day when you are going to sleep or when you are in isolation, when you are in public, when you are in college, when you are in office, don't wear it. This is the first thing you give the patient. Patient will be very happy, but don't omit at once. Then you ask the patient, okay, now you wear sometime in the day, but don't omit the night. Then you ask the patient, okay, one day you wear the day and second day you leave it, but you don't omit the night. For 1 week do it like this, and then you ask the patient that say one night you wear, one night you relax. So intermittently you increase the days. After 2 days you wear one, after 3 days you wear one, so on so forth. And it is better you ask the patient that when you are Sunday, you have a Sunday or Saturday, please have a try, don't omit it absolutely. So this how you gradually decrease the stabilization splint therapy. But if the patient is with bruxism, do not ask the patient to relieve your therapy at night, because he will brooks at night and your whole treatment will be vanished. So it is very important that for the bruxism patient, you have to go for long period till the patient omits the what you say is all Brooks happened. Second is the anterior repositioning splint. It's very important. Anterior repositioning splint, when you give a well-defined forces on the occlusal surface to actively guide the mandible into more protrusive position to improve the disc condyle relationship. Try to understand it. It is very important. You see, when we move the mandible forward, what happens? The disc remain there, but condyle move forward. Try to understand. This condyle has moved forward. Posteriorly there is space. Superiorly there is space. Anteriorly there is less space. Inferiorly there is less space. So the condyle is moved forward. Posteriorly you got the spaces. So that means that you have got the relaxation in the posterior limit. And this gives you the favor of relaxing posterior ligaments, number one. There will be more vascular supply in posterior area. There will be relaxation of the nerves as well. So by this mean, you adjust the disc condyle relationship. The disc will be right in anterior limit. This is that position where the condyle used to rest and love to rest, because at this level, the condyle will be in a more pleasing position. The vascular supply in posterior compartment is raised. The nerve, they are relaxed. And the main thing is that the torque on the condyle is reduced. So this is the function of anterior repositioning splint. Where to use? This is that photography. You see, this is the anterior bite plane I have given. The condyle is moved forward. This is anterior laminal. This is the 2 mm disc. This is 1 mm disc. This posterior limit is 3 mm. You well know that. And we are placing the condyle at 1 mm space by pushing the condyle toward the forward position. So posteriorly we got the relaxation. Anteriorly we have taken the disc with us. So the posteriorly we get the maximum relaxation, because now the nerve supply is relaxed. There is more vascular supply on the posterior segment, and the posterior bilaminar zone is relaxed. So that is the main area where we love to place the condyle. So that is the goal, to advance the mandible forward into a therapeutic position to maintain the disc in proper alignment and thus eliminate the pain and joint noise. You understand? Now there are slightly important things that you must understand in anterior repositioning splint. That is that when there is disc displacement with reduction, disc goes forward and then with a click it goes back. When the disc displacement is thought to be source of pain, anterior disc displacement, number one, with reduction, that can go back. Secondly, it is a source of pain. The disc can be reduced by moving the mandible only 2 to 3 mm forward from the interdigitation position or intercuspal position. This intercuspal position, you move the mandible not more than 2 to 3 mm. I prefer 2 mm, not more than that. That is more comfortable position as compared to 3 mm. So this is intercuspal position. You move the forward into intercuspal position, which is the natural position, 2 to 3 mm, move the impression forward and you interdigitate that. And this used to stabilize the splint has not reduced pain symptom. This is the option. If you see that anterior disc displacement is filled, then you are going to back on stabilization splint. For the patient with retrodiscitis, it is very retrodiscitis, the inflammation of the posterior portion of the disc. So when you place the disc in anterior portion, that means there is relaxation in the retrodiscal area, and there will be reduction in the splint. So that is the uses of anterior repositioning splint. But what are the drawbacks? When you give anterior bite plane, posteriorly it is relaxed. So what happened? That anterior or lateral, posterior or lateral, what you say, open bite result, and that is not a promising thing. So what we do, that we prefer that just for a transient period you place the anterior repositioning splint, but when you see that there is a relaxation, you give the what you say a stabilizing splint. So when you give the stabilizing splint, the occlusal balance will come back. There is one alternate, that at night you can give the stabilizing splint, and in the day you give the anterior repositioning splint. So you will reduce the chances of what you say lateral or posterior bite plane. This is very important to understand, that if you are going to use the anterior bite plane, you have to alternate the repositioning splint with the stabilizing splint at night. Now, this is hard acrylic resin for the anterior bite plane, and this provide the mandibular anterior touch only, and that you give an anterior bite plane, and it is specially recommended for the muscular spasm. Now we are coming to the posterior bite plane. The posterior bite planes, they are generally given when the TMJ decompression is required. You want to give more relaxation to TMJ, posterior and anterior ligament as well. So you place the posterior bite plane just to reduce the overloading. This is the posterior back plane. It is indicated in the case of articular pain symptoms related to inflammation localized to TMJ area. You just give the posterior bite plane, you don't shift the condyle forward, just give the space to the superior and inferior joint space, and this reduces the inflammation, and this is anterior disc displacement without reduction. This is very good when there is anterior disc displacement and not coming back to the fossa. So what you do, you create the space, and due to this space the disc rotate back on the joint, so the disc displacement is recovered by means of giving the splint of the posterior, creating the posterior joint space. So you try to understand, when there is anterior disc displacement, you are going to the repositioning splint, anterior repositioning splint. When there is muscular, you are going to give just anterior bite plane. When there is TMJ without reduction, you are going to give the posterior bite plane. When the disc will go back, then you will go for the repositioning splint, and so step by step you will achieve your goal. The drawback is right there, that if you are going to give the coverage of the posterior biplane, generally we get the posterior open wide, and that is sometimes not promising. And that which I have told you, that you give the stabilizing subplane as well as the bite planes. So anterior bite plane at night you give the subplane, same in the posterior bite plane you give the subplane at night. The last one is the soft and resilient or flexible biplane. In the initial stages, when there is in the very acute pain, patient comes to you, you will just give this supplement. For the temporary relief of the patient in acute distress due to injury or severe muscle spasms, just for the silicone made or flexible, protect the dental and TMJ structure against the traumatic injury during contact sports. This is a protective barrier, especially when boxing, football, or like that, even in the cricket, and by the trauma when you get. But it is not advised that you give the resilient splint for a long time, because it is very difficult to adjust, and especially for the polishing it is very you see very um, uh, not so strong, and for polishing and abrasion it is not giving you a good polishing surfaces. It is easily perforated. While bruxism, if you are giving this silicone type of supplant, it is going to give you the abrasion and it is going to perforate. So this is not a resilient supplant, is not good, especially for the therapy which is the permanent one. So these are the supplant which we use to give to the patient. What is the process, how we educate the patient for giving this therapy? When the symptom has been significantly reduced, you go on reducing the supplant therapy. When the patient is asymptomatic for a minimum 3 months, then you are absolutely going to omit the therapy. Discontinue the supplant use in a gradual manner. I have explained already. First stop the day night, and then stop the nights, and then intermittently giving the 1 day wear and 1 day relaxation, 1 day wear and 1 day relaxation. This you are going to relieve the supplant therapy. So ladies and gentlemen, this is a very important to understand when to use, where to use, how to describe, and when to reduce and when to omit. These all things are very important in appliance therapy. Now, physiotherapy is the next task. That actually last time I have given you the therapy. Few of you given me the post and 1-2 emails I have received that we want that you please repeat the physiotherapy again. So I am just giving you the recall of the physiotherapy. Physiotherapy actually is to relieve the pain of musculoskeletal innervation, improve and restore the normal masticatory function, and other associated. These physiotherapy actually give everything but do not give one thing. Remember, the occlusion. If there is discrepancy of occlusal plane, if there is disorientation of the disc, internal dearrangement, disc without reduction, then it is not going to work. Then you have to add this thing with the splint therapy as well. Now, one thing that the surgeon has to do, please listen.
The mass needs to be completely treated from the zygomatic arch all the way back, going slowly, releasing the tissue, all the way back to the back of the mandible, and all the way down to the angle of the mandible and forward. After the masseter is thoroughly treated, then I treat the cheek muscles and expression. Notice I'm not stretching them
Please see it again.
clearly towards the mandible. So the masseter needs to be completely treated from the zygomatic arch all the way back, going slowly, releasing the tissue, all the way back to the back of the mandible, and all the way down to the angle of the mandible and forward. After the masseter is thoroughly treated, then I treat cheek muscles and expression. Notice I'm not stretching them.
This is actually very important therapy for the masseter and the buccinator muscle, and to some extent it also gives relaxation to retropterygoid muscle as well. So this is the therapy. You have to start from the superior level, going back, and then to inferior level, and then moving forward. This I just for your I give you again.
So the masseter needs to be completely treated from the zygomatic arch all the way back, going slowly, releasing the tissue, all the way back to the back of the mandible, and all the way down to the angle of the mandible and forward. After the masseter is thoroughly treated, then I treat cheek muscles and expression. Notice I'm not stretching them.
So that is the physiotherapy number one, which the dental surgeon has to do. And that if you give this therapy at your clinic, I give you guarantee, the patient will go back home and tomorrow he or she will come again. Sir, yesterday you have given me the therapy. Please repeat that therapy again. I got a lot of relaxation by that therapy. This is a wonderful therapy. Please see this video again and again and try to do on your patient. Inshallah, you will get a good relief. Now, this is also and another thing for the occipital. Please listen.
This part of your knuckle, put it right behind this bone behind your ear, like this, with the fingers pointing up your head, and the same thing on the other side. Lift the suboccipital and pull down on the opposite side. Go to the other side, lift. Good. This one is amazing. People come in my office, they have a headache. Oh, give me the occipital. Get your knuckles in there. How's the headache? Oh, whoa. Now we're going to go up right up where the cheeks are. Find right where the cheeks go. Find some tender spots and you're going to open your mouth. This one's pretty intense. Feel the pain.
First one for the occipital muscle, and this is for the masseter muscle.
Ooh, a good one. You're not feeling it.
So you got my point. So these are the two therapy. Now move
They're
forward.
just incredible muscles. You can break a board with your jaw. I mean, it's about 200 pounds of force that you can exert.
Now it is revolving lower
In
part.
this video, we're going to work on the muscles, strengthening the muscles that open your jaw and relaxing the muscles that close your jaw. Speaking of muscles that close your jaw, muscles here, right up here.
This is temporalis.
A little bit. Excellent. You'll feel a little tenderness. Seek out tender spots and then massage them out. If you're feeling tenderness, you're on the right spot. Keep going. Good. Smile. This is going to be great for you. While you're in the carrying office, we want you working at TMJ every day. Okay, the next exercise.
Now,
Start with
next.
your left hand. And you're going to reach it
You
around
see,
the
this
back.
is for the neck muscles.
Get your fingers right underneath your skull. Get right under
Trapezius.
there. Feel it. You're going to have a little tension under there. Get that middle finger in there, do some cross fiber massaging. Find any tender spots. You can go a little bit below the suboccipital, bring your head down a bit if that works better for you. Get way over to the side, cover the whole span of it. And just work it right in there. Give yourself some attention. Let me hang on for you.
Near to external occipital protuberance.
So we're going to switch to the other hand. Just dig on in, people.
These are generally the hot spots which he's touching.
Well, it's not about healthcare as much as it's about self-care. You are with you 24/7, and a little care to yourself is going to go a long way. Bring that head down a little bit. You got to get in there a little bit more. Next, we're going to do the open mouth. Put your head at 45 degrees.
The
that chin
overall
and
sternocleidomastoid and the neck
I want you to
muscles.
feel that suboccipital open up a little bit. Keep the chest up. Take a big breath in. As you breathe out, just pull a little bit more. Big breath in. A nice big pull. Great, let's go to the other side. I'm doing the mirror image of what you're doing, so grab your right hand.
The same way you are going to do the other side. The next is occipital line, especially
process. Fingers go up the sides of the head, and we're going to lift the skull as you pull the opposite hand down, and then go to the other side. So it's lifting on this side, pulling down.
These are both sides of occipital, sternocleidomastoid and neck.
You're going to feel some freedom when we're done with this. Oh, my head feels lighter. Push your tongue.
Now tongue and eye movement, I are already described, but this is good, just repetition.
Each one.
Eye opposite side, tongue
Keep
opposite
going
side.
back and forth on this one.
Eye opposite side, tongue opposite side.
To the opposite side that the tongue is going. Push that tongue to the side of your mouth, look to the opposite side, and switch. Make sure your mouth is open on this, wide open, not closed.
So this is we have already seen, and this is the tongue
Really
pushing back,
the muscles that keep your mouth open.
pushing back,
Woo! If you like, close your eyes.
and then relaxation.
Think that word happy with every exhale.
Relax, taking the deep breath, and that is the physiotherapy which is recommended for splint. Now the pharmacotherapy we have discussed in detail before, but just for the conclusion session I want to give you the detail. It is just to control the pain and inflammation, and it is generally promising that when you are giving splint or physiotherapy or other things, we generally favor that initial stages should be given. Analgesic in the start, prefer paracetamol. If not effective, then go to mefenamic acid. Non-steroidal anti-inflammatory drugs, ibuprofen, naproxen. Naproxen not advised at all in the initial stages. Ibuprofen after mefenamic acid. Remember, these both drugs are very big nephrotoxic as well as hepatotoxic. The safest is the paracetamol. I will prefer that you do not go for the ibuprofen and naproxen in the initial stages. Muscle relaxant, to some extent, when you think that there is hot spots, then methoxylon is not recommended in the initial stages, but the very severe and old patient. Anxiolytic is when acute stages is there. Do not prescribe the anxiolytic for the long therapy because the patient become addicted to these. So it is very important that just very little doses and very initial stages doses it should be given, and especially try to prevent the young patient not to give anxiolytic. Antidepressant, I will recommend that the maxillofacial surgeon, dental surgeon should avoid giving antidepressant. It is the work of the psychologist and psychotherapist that it is better that you refer the patient to psychologist. But anyhow, if you are in such a condition that you have to give antidepressant, you give it, but remember, not more than 15 days, then you have to send the patient to psychologist. Lignocaine patches, we have discussed in detail lignocaine, even patches, even the injectable form. Now, what is the behavior therapy? The behavior therapy is very important, and that is that you have to manage the noxious habit accompanying the muscular skeletal disorder. For that purpose, acupuncture, hypnosis, biofeedback, and relaxing exercises, they are recommended. The acupuncture is very promising, but it should be done with the very expert hand. However, hypnosis or yoga, I will say they give you a good result. So these are the behavior therapies which must be associated or may be associated with it by the expert people, but no doubt they have proved to be very effective. Ladies and gentlemen, then we have the long-term management. These are the emergency initial therapy, but the long-term management is just to understand it. Re-evaluation of the patient, responding well to conservative measures at the conclusion of initial therapy. But the initial therapy you have given, they are actually the long-term management. They are actually the continuation of long-term management. A trial period of weaning the patient for an occlusal appliance is often implied with the periodic monitoring. You go on monitoring the occlusal therapy appliances, and then you are going to reduce it. Determining whether a change in the present occlusal scheme is necessary or not. Whether I have to give the posterior biplane, whether I have to give anterior biplane, or I have to give the stabilizing. Evaluation of the precipitating factor. Whether patient has got the relaxation, has omitted its period of tension, it is patient is not doing the bruxism, patient is not giving the nail biting or different what you say the bad habits, has omitted all these things. If you have sure, then you are going to change the therapy. Ladies and gentlemen, with that is the conclusion of all our TMJ seasons, which we have covered in 4 seasons. With that, I'm thankful to all of you. And ladies and gentlemen, it is over to the organizers for the further discussion. And thank you very much, all of you, for patients listening. Yes. If you have any question, I am here to answer your question. Dr. Rehan, it is over to you.
Thank you so much, Dr. Arshad. If anyone has any question, you can ask in chat box also, or you can ask in live by raising your hand. We will unmute you. Sir, I'm forwarding you some questions. Kindly answer those.
Yes.
For patient who are highly stressed and clenches, does he wear for lifetime?
No, I have explained it very nicely. I explain again to you that the bruxism is a habit when it is going to be controlled by the appliances. It, with the passage of time, is used to go away. I have seen so many patients, they were bruxed for even 20 years. And when we have given the therapy, they within 6 months to 8 months, they have left the bruxism. So especially for the ladies, I have seen that it generally used to occur very early. So it is never advised that you go on wearing the appliances whole the life. Yes. There is one question I have received from Sadia Bhatti, that she's saying that these exercises, physiotherapy, are given before the correction of TMJ problem or after. No, this is beside to the therapy. You give the occlusal splint or you give the splint therapy, and side by side you have to give the exercises. There is one question also from the Sadia Bhatti. She says that anterior bite plane is the same appliance we give the anterior repositioning splint. Anterior reposition, no, it is different. Is that the anterior repositioning splint is an anterior bite plane is entirely different. Anterior bite plane is given when there is more muscular problem and it is given relaxation to the muscle of mastication. But the anterior repositioning appliance is given just to give the relaxation to the joint. When we will get the certificate? No. Sir, you cover the surgical treatment in next or not? The surgical treatment actually is beyond the limit to this TMD, what you say, sequence. We have described in the initial stages that we are not going to cover the surgery in this because this is a bigger postgraduate session, and it is especially recommended for the maxillofacial surgeon and their students. So for the general dental surgeon, it is just I think that wastage of time to giving detail of the surgery or giving my cases which I have done. My email is very simple. You will write down the lowers, Dr. DRARSHAD Malik 56 @gmail.com.
Thanks, Dr. Arshad. There are also private messages also.
Yes, please.
For patients who are highly stressed and clenches, does he wear for lifetime?
No, I
Sir,
have
can I
explained.
repeat?
Yes, please.
For patient who are highly stressed and clenches, does he wear for lifetime?
Actually, the pain is a very bad thing. You see, for the diabetes, I used to take medicine whole the life. For hypertension, I take the medicine whole the life. For asthma, I used to take the medicine whole the life. For arthritis or pain in the joint, I used to take the therapy whole the life. So if the therapy is like that, that the patient is a chronic patient and could not be stabilized for a short period, it is very nice that he can take the plain occlusal supplement for life. Yes.
So next question is, for how long will we ask the patient to continue wearing the splint in chronic cases? And when patient has the habit of bruxism in both day and night timings?
Actually, this is a question, especially I have explained everything. It is a question of the patient management. That when the patient comes to you, you take the MRI, you take the what you say OPG, and you evaluate the disc position and loss of the joint. Then you see the habit of the bruxism, how much the habit of the bruxism patient has. Then you see the age of the patient, it is a young, it is middle age or old age. And then you see what is the cooperation of the patient, that how much the patient is cooperative with you, and what is the excitability parameter of the patient. If the patient is very cooperative and if the patient is well behaved, the therapy generally after 1 year you start omitting the therapy. But if the patient they are not cooperative and they are not obeying, sometimes we have to repeat the therapy after 1 year, and we have to change the therapy parameters as well. We have to include the different exercises. We have to monitor the patient every week or after every 15 days, and we have to look for everything. And then we have to add the heat and cold sponges as well, with the help of analgesic as well. So this is all your assessment, your diagnosis, how you assess your patient, and what is the criteria of the disease and what is the intensity of the disease. Yes, yes.
Uh, uh, Now there are end of questions. Thanks a lot, Dr. Rashid, for this wonderful session. Now I would like to invite our CEO, Association of International Dentistry, to speak some words. Now I would like to invite.
Yes, thank you.
Assalamu alaikum. Thank you so much, Dr. Arshad, and as well as Association of International Team who have organized such a beautiful series of on TMJ. Thank you so much, Dr. Arshad.
I will love that these children, these students, they are very, what you say, conscious about it, and that they have. I have seen so many queries and so many things from done during this whole seminar. So we have the opportunity to, inshallah, to continue this system again, and we will discuss the topics. And inshallah, there are many latest topics as well, especially the lasers, soft lasers. There are many related things like trigeminal neuralgia and other things. If and especially there is a other thing as well for the young generation, that is exodontia is also a very missing chapter in our young generation, and especially they are missing the basic techniques and basic things. So there is a lot of topics for which we can have the seasons. And I am especially very much thankful to you, and especially today's the organizer, Dr. Maham Chaudhary, that she been very kind, that she have participated, and she have given time to the association. And thank you very much for everyone. And inshallah, I will be there if there is anything that I can serve the association for the longer go.
Inshallah. Thank you so much, Dr. Arshad. And we are definitely planning something big also, and we will keep you with us. We can to close the ceremony. Dr. Mam, you can continue. Thank you so much, everyone.
Thank you very much. And goodbye, good night as well to everyone. Thank you.
Okay, thanks, Dr. Rehan, for your kind words. Now I will guide you about how to get the certificate. And important thing about certificate is that it is internationally accepted. And to get certificate, you have only registered members will be able to get the certificate. And to get a certificate, go to the AID website, register, watch video on the easy attempt your quiz, and we will upload the quiz in the next 3 days, and it will be available on the AID website for 24 hours only. You can also ask any question in the YouTube live video and in the FB page post. And make sure to follow our Facebook page for lively updates. Subscribe YouTube channel to get old and new courses of AID. Thanks and Allah Hafiz.